Everyone. Ooh, sorry, everybody. She was like, what? I woke you up. I did, didn't I? All right. Hey, everybody. We're just really glad to have you here today to have some fun conversations on the successes and challenges that we see in accessing ABA treatment right in our state. So we're really happy to be here with you today. I'll start us off. I'm Marla Root. My son is 29 on the spectrum. He's a level 3. He would probably, I think there's a lot of movement around using the word profound autism. He does require 24/7 care. He's an amazing human. I was telling everybody last night, my son is 6'8", 300 pounds, so he's about LeBron James size. I love the NBA. And so you can imagine, when you have challenging behavior of somebody of that size, he's kicked out my windshield in my car, and, but anyhow, he is an amazing human now. So he's 29. We kind of went through a period where he was a lot unstable between 15 and probably 18 and a half, but he's doing great now. So it's really fun being his mom. And then through that, I became a provider of ABA services in the state of Ohio, one of the first to actually bill mental health services for autism. We won a really big lawsuit there called Please, which really helped develop the medical necessity criteria for utilizing ABA, which is applied behavior analysis, in case you don't know, therapy. And then I was a provider for a long time, and now I have a consulting business that I support providers in the state of Illinois and Ohio around challenges they face, right? So we're working on reducing barriers for families and also the provider network. And I'm also on the insurance committee for the Autism Insurance Coalition, the Autism Task Force.
Hi, everybody. I'm Shannon Dyson. I'm currently the director of the Autism Program of Illinois. Before I got there, though, my clinical background, I started working in college, actually, as an ABA therapist in families' homes. That's where I started really loving the field. And then all my schooling from that point on just was all that. So I've always worked in outpatient behavior clinics and hospitals. I have actually crossed paths professionally with Marla. And so it's been a pleasure to work with individuals and utilize the field. So thank you.
Hi, I'm Dr. Jamin Demering. I am currently a practicing BCBA. Most of my work right now is actually with youth in foster care, but I've been working with folks with autism and developmental disabilities actually since I was 16 and able to drive. That was my very first job. So been around the field a long time. I'm here as a representative of ABA. I'm the Legislative Affairs Committee Chair with ABA right now.
All right, so I do want to share that, some of the language that we're going to use is very insurance-based type language. So I just want to make sure everybody's aware. So we talk about medical necessity. We'll talk about deficits, core deficits of autism. It's kind of it's not a super friendly, nice way to talk, but it is what we do when we're talking about accessing treatments, whether it's ABA, speech, right, and so forth. So I just want to make sure everybody's aware of that. We may use ASD a lot, right? That's autism spectrum disorder. Jamin just introduced herself as a behavior BCBA. That's a board certified behavior analyst, just in case you don't know. And ILABA is the practitioner association. So all the behavior analysts, they have their own association. So she represents them. So. And we may talk about the structure of ABA. So our behavior analysts, our psychologists, right, these people that design and build these treatment programs for these kids, they're kind of the supervisor. And then we have our technicians, our registered behavior technicians that actually deliver the treatment. So that may be talked about a little bit. I'm trying to think of course, ABA is applied behavior analysis. Is anybody here not familiar with ABA and what ABA therapy looks like, what it does, or anything like that?
A little bit, but I'm getting a bigger picture.
Oh, great. That's great. Do you guys want to give a little blurb?
that okay? So applied behavior analysis is a therapy that we really look at the behavior in the context, like of the environment. And so behavior analysts are kind of trained to observe the behavior, figure out why it's occurring, and then we make changes to the environment so that we can get different behaviors. So that might be reinforcing, like kind of rewarding a behavior that we do want to see. We really try to rely heavily on proactive strategies where before the behavior even has an opportunity to occur, that we're trying to set up the environment for success. And so it's very data-based. The clinicians kind of take data on a daily basis and monitor how effective it is, and we are readily making adjustments to our treatment plans to make sure that we're getting the changes that we hope to see.
So let's get an idea of who you all are. That may help drive some good conversations today. So do we have parents or guardians in the room, grandparents, okay? A lot, okay, good. Do we have any service providers, whether that's delivering ABA treatment, speech treatment? Awesome. Do we have any developmental disability waiver providers that may be here? Yes, good. That's awesome. Any practitioners, whether social work, psychologist, behavior analyst? Yeah, perfect. How about school districts? Anybody from the school districts? Okay, great. All right, am I missing anybody else we should ask about? Anybody else I didn't hit your category? Okay, great. Well, what we're going to do is we're going to start off with successes, right? We're going to think positive, what's been happening, what's working, and then we can kind of get into some of those challenges that we still see. So, I'll start off. We had obviously the autism mandate law passed many years ago, right? And what's exciting today is we see less denials for treatment services, whether around ABA or speech type things, based on the child's age, number of hours or the intensity of treatment, right? And then the visit limits. And so that's really exciting. And one of the things I do want to share is we're going to talk a lot about some of the patient protections that there are, but when we provide speech therapy for kids with autism, that carries patient protections with them. So we shouldn't be told by our health insurers that, hey, listen, you only have 20 visits a year of speech. Now that may be true depending on how the speech person's billing, right? But so there are these protections that support in regards to speech therapy that some kids need more based on the ASD diagnosis. And we're starting to see more plans put in their plans that, hey, if the child has autism, we don't limit speech and OT and things. So that's a good positive.
I have noticed through the requests for services in our network, just the access, that there are opportunities for people who did not otherwise have the opportunity to have ABA as an option, which is great because it has allowed them to embark in that service delivery. So.
I'm not sure exactly what Marla wants me to share here, but I'll share a few things that have kind of come up with ABA that are positives. We are meeting regularly with HSF to try to address barriers, and when we were meeting with Director Whitehorn, she just very directly stated that autistic kids in the state should be receiving services if they need them, which was really, we're really optimistic about that position, that they want people to receive the services that they need. There's also a new neurodiversity caucus, which apparently just started. They had an event earlier this month, and it sounds like it went really well. So there is interest around the state to make sure that neurodivergent individuals are well served. And so I think those are a couple successes that we've recently had.
One thing we have now, which we've never had, we have a nonprofit produced standards of care. So when you look at like mental health, alcohol and drug treatments, those services, those behavioral health services have had generally accepted standards of care for years and years and years. So everybody in the industry agrees upon them, right? We now have them in regards to ABA therapy for the treatment of autism. And that's a really big deal. So, you know, one of the things I do like parents to go out and look at those. It talks about how ABA should be delivered, who does what are the services, like the billing codes that would be used, explains them. It's really a good way to, if your child is looking to get in and get ABA treatment. So they're called the practice guidelines, and the practice guidelines were generated by CASP, which is the Council of Autism Service Providers. And just amazing people doing amazing work there. So the practice guidelines, that are our standards. We use these when people tell us no when we want to get treatments, maybe an insurance denial, and we say, hey, listen, if we look at the standards of care, and usually, like if you're in the Medicaid system, I did a hearing recently, and when I bring up, but wait a minute, we have these generally accepted standards of care, the hearing officer goes, oh, well, we want to hear that, right? Because that carries that kind of weight. So that's a big success for the community, for sure. What else? Anybody else have anything on top of their mind?
I think just one thing I wanted to mention, we can put resources on Behavior Live with like the standards of care and the documents that Marla is referring to. We'll make sure that you all have access to those.
Yeah, I think I did list 8 references, so I'm hoping those are on there, but we'll make sure they're on there to make it easy for you guys. And remember, you can listen to the speech again, right, through Behavior Live. I think a fun thing to also talk about when we're talking about successes is accreditation. So, you know, when you go to your physicians, you go to your podiatrist, you go, whatever medical or other behavioral health services, maybe you get like community mental health services. A lot of those places, most of them are accredited. We now have that for ABA therapists or for companies. So you might have been in the panel earlier today. I know that was to talk about. So, you know, monitoring that, right, is always a good thing for families to know.
Another thing that just went into effect this year is the Behavior Analyst are getting licensed. I think we've got a good chunk. We're still working on it, but previously it wasn't required in the state and it wasn't an option. But that is a protection, you know, to consumers to make sure that there's an extra layer in the state of Illinois to make sure that everyone's kind of meeting all of the standards of care, that there's a way that if anybody's doing anything inappropriate in practice, that there's interventions with that. So it's, you know, really legitimizing our profession, which is cool.
Do you have one?
I can mention, we do have, in the state of Illinois, we have a task force, an autism task force, and there are efforts and a lot of people who come together for the task force meetings, caregivers, people who have autism, providers, coming together collectively to determine what is needed throughout the state and make recommendations on what is best. And part of what was recommended was being able to get coverage for ABA services through Medicaid. So it was a very long process with lots and lots of people contributing to that, but there's lots of people who are advocating for using these best practices to better serve individuals.
Yeah, and then another big success, this legislation I think was passed at least 2 years ago, but it is now in full effect. So if any of you have Blue Cross Blue Shield as your commercial, and I would assume on the Medicaid side, I'll have to check with Medicaid, but at least on the commercial side, I just want to read the sentence because I can't describe it probably a better way, but it opens up ABA therapy and services needed for like other people other than just, you know, autistic people. So this talks about, so it just started in January, that insurers shall provide coverage for therapy, diagnostic testing, and equipment necessary to increase quality of life of children who have been clinically or genetically diagnosed with any disease, syndrome, or disorder that includes low-tone neuromuscular impairment, neurological impairment, or cognitive impairment. So, this is fascinating. We have been talking with Blue Cross Blue Shield on some other challenges, and they were here today, this conference, and that's a huge success. To see an insurer of their, size in the state to be here and supporting the TAP conference was amazing, So I just wanted to make you guys aware that, for kids, right, who would not have autism but do have cognitive impairment, neurological impairment, it is right here in their policy for ABA. So I just want to share that that's a big success, really. All right, so we'll probably talk about some more successes as we go, but let's talk about some challenges. And you want to talk about, as our psychologist here, diagnostics and some of those requirements that we see that hinder getting access to treatment timely.
So for a lot of insurance plans to cover ABA, they want a diagnosis of autism. But what we're seeing throughout the state is there's barriers to gaining access to a diagnostic evaluation, really, really long wait lists for individuals. And the older you get, the harder it is to find a variety of providers who are able to provide it. And so it's kind of creating roadblocks to gain access to the actual service because those insurers are wanting to have that diagnosis. So there has been talks, at least in the Autism Task Force, about diversifying the number of providers that could provide that, or providing a provisional diagnosis as a means to help individuals gain access to service earlier instead of having to wait for that diagnosis. As Marla said, everything's dealt in the medical model, so it's like that deficit base. So they want to tie, a diagnosis to why that service is being provided. So trying to kind of think what are other opportunities to help streamline access to care, so there's not all of these bottlenecks that is really slowing things down. That's for our network and for our grant. Our number one requested service on our referral database is screenings and diagnostics. Our very close second is ABA therapy. So, and you have to have one to get the other. So it's really a challenge for many individuals throughout our state.
And kind of on a similar note, we are, in our talks with HSF, we're also trying to decrease the need for a full diagnostic reevaluation. It seems like there might be some different interpretation of the language, but that's something that we've seen some kids get denied for because they don't have an updated evaluation. So we're working on that in our advocacy with ABA right now.
Yeah, HFS is Medicaid, right? So even though obviously that's one of our big successes, it was slow rolling out. It was slow being available. The behavior analysts, which are the experts in delivering ABA treatment for autism, needed to be supervised for a while. You had to find this unicorn, which we found out there. I think there was 28 in the state that they would have to create time in their current caseloads on whatever services they provide, more mental health and probably addiction type services, to supervise these behavior analysts. That we got that fixed, so that was a big success. And I think today I got an email. So we're talking about this stuff, but let me show you how this really impacts people. A managed care plan just told a provider that, hey, you're asking for us to approve a prior authorization. So that's where your ABA provider says, hey, yeah, we think we can serve you. Let's do an assessment. They do these simple assessments. Then they create like a treatment plan, and then they determine how much the dosage of ABA will be, right? So how many hours and what services and so forth. And then they submit a prior authorization to your health insurer. And then the health insurer says, okay, does this meet medical necessity, right? So does the child need this? Does this meet our medical policy, standards of care and so forth? And then they'll either approve or they'll deny. So literally this morning, this provider sent the prior authorization in for a child, and the MCO told them, yeah, I wouldn't really submit this because we're going to deny it. And they said, why? And the kid's like 6. They were going to deny it because the diagnostic evaluation that was completed was now 2 years old. And so this is the reality families face is, okay, I just got my child diagnosed and he's 5. I'm going to have a re-diagnose in 2 years. You know what that means? I'm going to be back on the wait list in 6 months, right? So, okay, I'm diagnosed today. Okay, this is 2025. In 2026, I got to get on the wait list. So this is a big barrier. Normally, Blue Cross Blue Shield would be a good example. And some other insurers are saying, okay, well, let's just get a letter from the child psychologist that they continue to need services. But for an MCO, and really any insurer, doesn't matter if it's a commercial insurer like you get through your jobs, your employer-based insurance, or if it's public, the Medicaid, nobody should ever say you should not submit a prior auth because we're going to deny it. Because guess what just happened? The family didn't get a denial letter. So now I'm going to have to call Medicaid, and and I think Jamin mentioned that we've already been talking to Medicaid about this. And they've had some very good, favorable responses, so we'll see where it goes. But my goodness, we don't have enough psychologists, right, to do all the initial diagnostic, until I'm not a clinician, diagnostic services, and then do the re-diagnosis for continuing of any type of treatment. So, and I will say that, I, as a parent and my provider network that I run, the coalition, we're advocating we have to expand the practitioner types who can diagnose. We just don't have enough psychologists. And, we don't have enough. I mean, we see licensed clinical social workers. They diagnose in the mental health, type array. So there's advanced nurse practitioners, and obviously our pediatricians. So all these people would get the training. It would be in their scope of practice. And when I mean diagnose, I kind of mean like a preliminary diagnosis. That, hey, we did the testing tool. The testing tool came out and said there's signs of autism here. Then the kid should get access right then and there. And then they can go get in line for one of these massive, what we call comprehensive diagnostic evaluations. And I'm going to let her clean any of that up.
No, you're right. It's hard for families to not only gain access, but then meet all the standards for each of the companies, because some want specific testing instruments, which are only certain provider types are able to actually administer, and then having that reevaluation every couple of years is hard, because once you're diagnosed with autism, that's something that you're going to take and live with, and it's not going to likely change in a couple of years. So it's a lot of extra work for families to kind of jump through some of these hoops, just as a means to get the support that they need.
Jim, you want to talk about provider access?
Yeah, so I think that one challenge that we're seeing, and I especially see in foster care, is that there are not a lot of providers, specifically Medicaid providers. It can be challenging. We're really working on trying to identify what the barriers are and fix those to get more people involved. So even if somebody has access through their health insurance, they might have difficulty finding a provider. I think that another difficulty that we see is there might be some providers, but they have a very specific way that they provide services. So it might just be in clinic, and somebody might need services in home, and that can be a challenge. The population I work with now is all teenagers. And so when we're reaching out to providers who do take Medicaid, we're frequently being told that, like they don't work with kids that are teenage, and, they want the younger kids. So that's really created some difficulties, and that's in Chicago. There's tons of providers, but not all the kids that need services are able to get it because there's not enough providers that are actually providing the service for diverse needs. So I think that's something that we're still dealing with quite a bit and trying to figure out how we can support providers to get more involved with the MCOs.
I would also elaborate as you move down the state, there are fewer providers who accept Medicaid, so it's even more challenging for families to find a provider. And as I said, those services might have a small scope, whether it's more intensive clinic-based. Very few have a focus in the home, and there's all different age ranges for a lot of the service providers. So it's like trying to find the right fit could be very difficult.
Yeah, and to speak to the point about the difficulty in the southern part of the state, my department works with youth and care across the state, and we're having a hard time even finding a single provider in some of these counties to even just make a consultation request. And so there's a lot of people that are just in kind of ABA deserts where there's just not a lot of services happening, and then those providers that are in that area are overwhelmed, with the referrals that they have, which is also a challenge.
I think, we're going to definitely open this up to hear from you all here in just a little bit. We kind of just wanted to kind of get some of this out. I know one of the things, and hopefully Jamin didn't say this and I missed it, but so remember that direct care staff that deliver the treatment, right? The behavior analyst monitors, develops, supervises treatment, the technicians deliver it. In one of the challenges we're having, especially in Medicaid, they require the provider have a registered behavior technician. So this is a technician who's done the 40 hours of training, they've been supervised, they've been working and learning how to deliver these interventions and so forth, and all the behavioral principles, right? Because behavior analysis is the science of behavior. And then if they're competent, right, the behavior analyst is like, hey, you're competent, then they can go take the test. And they got to pass the test, obviously, to become a registered behavior technician. So what we're trying to say is because, and just so you guys all know, and you know this, that right now there's just a staffing shortages in mental health, addiction services, and we feel it in ABA, and probably in speech too. So we're trying to explain that, hey, listen, if the technician is competent, right, the behavior analyst has tested them, there is an actual competency assessment, and they pass it, they should become billable right then. So let's get a kid off the wait list, let's get them in, right? And then that technician can then go take the test, get accredited. So we are asking for like a grace period, like a 120-day grace period, because providers right now have to carry the cost of that technician like 3 to 4 months before they can even bill them. That's expensive. If you're a business owner, you understand. So we're really working to fix that.
Yeah, and just to kind of piggyback off of some of the things that Marla was talking about, once somebody's eligible to take the test, they then have to find a testing center to do that. They do get their results right away, but then they have to enroll in Impact, which also takes some time. And so there's quite a few reasons why it's taking so long for RBTs to get to that point that they're billable. And again, that's something that that's probably like the issue we're talking the most with HFS about right now, trying to address that, because our providers are communicating that that's been a real challenge.
Yeah, and I think too, I know like we're on the insurance committee at the Autism task force in the state. They're doing really good work. You know, they have committees in adult services, insurance, early intervention, and adult services. So if anybody, and you can dial in and listen. There's like, I don't know, every quarter there's a big meeting, but then, you know, there's these little committees, and please, you know, I can definitely connect you, or you can probably just Google DHS Autism Task Force, and you'll get it, and you can join. So I want to make sure you know that. And they're doing a lot of work around early intervention, right? Making sure kids are getting into it and getting what they need. And then one of the things is, you know, making sure kids get that medical diagnostic too, right? They go on to school, and the school assesses them and all that, but, you know, make sure they get that medical diagnostic so they can access services there. So there's a lot of work, insurance. So the task force, what they do is they, you know, they set these goals, and really the goals are around what are things the state should do to improve the lives of people with autism? And then they send that report to actually the Department of Human Services secretary. And so that could be anything from, you know, foster care, residential mental health treatment when our kids are in crisis. It could be the waiver services. It could be ABA or medical treatments. And so just so you know, they're doing a lot of work, but you could always join in and listen, provide information about what's happening. And I definitely want to talk about, so there's a couple of things right now. If your kid's in ABA, you may know when you go to your child's center, the technician may give you an iPad, or they may give you a pencil and paper, and you have to sign your name to the note, to the progress note, session note, they may call them. Right now, there's only one insurer in the state that requires that, and nowhere do we have to do this when we take our kids to get speech and OT, or even just the medical doctor's office. And so, you know what that's like when your kid comes out of therapy. It's all chaotic, right? And they want you to sign, which could be 5 to 6 notes a day, and it's silly. And on the flip side of that, for the provider, it creates a risk. So if I delivered you the services and I couldn't get you to sign the progress notes, if I get audited, I have to pay that money back. And normally what happens is they'll say, oh, Marla, you missed 5 signatures out of your 30 clients, and then they extrapolate that over a period of time and just assume you did it on other records that oh yes, this is how it works, other records.
That's so uncool.
I know, right? And that's what happens, especially in Medicaid. They'll extrapolate it. So, you know, you may have missed 5 signatures, so now you got to pay back, you know, $4,000, but they're going to extrapolate it over all the billings. So those error rates. So just so you know, so we're really trying to talk to the insurer to say, listen, we don't need parent signatures. You don't do this anywhere else. And it's about why treating people with autism differently, right? You're treating ABA treatment different than you are from speech. You're treating the diagnosis, somebody with ASD differently than other mental health services, other conditions may go get access to. Which I think can drive us right into the conversation of patient protections. Okay, so right now, remember how we talked about the language today may be a little different. Autism spectrum disorder is in the DSM, right? Statistical Manual of Psychiatric Disorders. And that means that it's considered for insurance as a mental health condition. Because it's considered as a mental health condition, then we have these patient protections. And the big boy is called MAPIA. And it's like the Paul Wellstone Mental Health Parity Law, something like that. So basically it says, and you guys, you know, you may know some of these things that have occurred and really impacted families in the past, and that people seeking mental health and addiction and behavioral health services cannot be treated differently than patients on the medical surgical side. So what used to happen for forever, oh, you have anxiety, you need counseling. Well, we don't really have very many people in our provider network, so you'll have to go out of network to find a provider. And what did that do? It raised those copays, because I have less coverage because it's out of network. We had, unfortunately, a young man need a residential mental health treatment. I think it was for addiction services, and the insurer kept denying. They used their own standards of care. They created them, the insurer did, right? Not the professionals on the outside delivering services, but the insurer, and they denied him, and unfortunately, He overdosed about 30 days later. Now that is a big case, and that case is rocking the world around this now, right? So it kind of goes back to, that's why those generally accepted standards of care we talked about, that, you know, people like Shannon and Jamin, I mean, the practitioners actually delivering services, working hands-on with the kids and adults and so forth, built those. And that's why it's so important that we take that, that's our control of what we need, and not allow insurers to create their own standards. So MAPIA is the Federal Mental Health Parity Law. It's really MHPAEA, MAPIA. But if you type in Federal Mental Health Parity Law, it'll come up. That is, we hold that dear. Because basically says that, hey, listen, anybody seeking mental health and addiction services, you can't deny them based on age. You can't put an hour cap or a visit cap. Big deal. And then the other is EPSDT. So MAPIA works for people on the commercial side of a health plan and for people on Medicaid that are enrolled in a managed care plan. For people for kids 21 and under, those patient protections on the Medicaid side is called EPSDT. It's early periodic screening, diagnostic, and treatment, EPSDT. So it's called, and if you think about it, it's like the federal Medicaid mandate. Does anyone, you want to talk about EPSD a little bit, just about the patient protections? You can see what the name, or I can. I'm talking a lot here, so I just want to share. Okay. Yeah, okay. So we have these patient protections, right? We got the Federal Mental Health Parity Law, MAPIA, on the commercial and the Medicaid managed care plan side, and then we have EPSDT on the Medicaid side. And basically EPSDT says we don't care what the kid needs, we care with what the kid needs, and you better give the kid what they need, right? If they've been, so like if your child's been diagnosed with a rare disease and there's nobody in the state of Illinois with the expertise, they need to take your kid and go to Ohio, New York, somewhere where the expertise is. It is a strong. So if you ever get denied in the Medicaid system, say, what about EPSDT? Remember I told you we won that big lawsuit back in the day? We used EPSDT in a meeting, and the people in Medicaid didn't know what it was. And the reason why they didn't know what it was is they had renamed it in that state only. So we kind of have, they called it health check, which I get, it is easier than EPSDT, but for some reason, they weren't aware that, you know, so that's what we deal with. Now, thank goodness, you know, there's been years of fighting around all this and advocating, and things have changed. So MAPIA on the federal, and then EPSDT on the Medicaid, and then the other thing you have is an incredible state law here for parity, right? That your legislature said, listen, yeah, no, we love mental health parity law, and we're going to make our state law match it. Big deal. That's a big deal. So I want to make sure we get through that. Maybe we can talk about some quickly comprehensive and focused ABA in adults, teens, and then we can kind of open it up if anybody wants to.
So when a child or adult comes into ABA services, there's different types. You know, sometimes somebody might just be receiving some brief consultation, or there's focused ABA where there's a specific issue that the team is working on. And then oftentimes we see it more with younger kids, but there are older kids that need comprehensive ABA services. And that's where we're providing services across domains. So somebody that's receiving comprehensive ABA may be getting supports to acquire skills to do self-care, working on communication, addressing their behaviors, so really across different domains. A lot of times the number of hours that somebody is assigned kind of corresponds with the type of ABA that they are receiving. Not always the case. Sometimes you might have a focused issue that just takes a lot of time because of the intensity. So there are different ways that those services can look when you're involved with ABA services.
So There are certain codes that are utilized and were created. They're called CPT codes, and they're really justify specifically what is captured during treatment, and it really helps quantify what is being done. And it's universal amongst all providers and all the states. And so that's really helped, I think, streamline what's being done and capturing everything that's reflected within the service delivery, within the scope of ABA across providers, in my opinion. In my humble opinion.
That's right. Big deal. Okay, so I want to go back to, right, so you go to your ABA provider. They're like, yeah, we feel like we can serve your child. We're going to do that prior authorization to your insurance company. And then that's when the insurance company deems whether it meets medical necessity or not. You've probably had this done with physical therapy. I had to rehab my knee recently. You know, does it meet medical necessity? So I just want to give you the definition of what medical necessity is. And remember, language is very clinical and insurance-y, or whatever you want to say about it. So the elements of medical necessity generally refers to treatments that ameliorate, which means lessen, symptoms, manage symptoms, improve symptoms, or maintains functioning, and or prevents regression and deterioration. So one of the things I want to make sure you understand, if your child's getting ABA, so they've been authorizing services, and then they say, hey, listen, Johnny is just not making any progress. We're going to deny. You're done with ABA. You need to go get a lower level of care. Now, this happened with my own son, kind of when we were in that behavioral crisis I mentioned, and I was like, wait a minute. ABA therapy is the only thing that's keeping him stable at the moment. And that was very hard. So in that definition, it mentions improve or maintain functioning to prevent regression. So we had to fight for that, because on the days he didn't have ABA therapy, he was up and down, and it was very clear that the ongoing treatment, even though he wasn't really making a lot of progress because we were in a bad behavioral state at the time, he was maintaining functioning, and he relied on that treatment to do that. Okay, so I want to make sure you guys know that. Big deal there. And that kind of leads into, denials and appeals. We do see them. So like if you get a denial, you can file an appeal with your insurance company, and that's usually what they call an internal appeal, right? It's just you and your insurance company. Sometimes we lose those. We don't lose them as much as we used to, but if you do lose them, the good news is we tend to win them in external appeal, which means, okay, insurer, you denied me again. You denied me twice, right, when we asked for it, and then when we went through the appeal. Now I'm going to go get a third party outside of the insurance company to do an external appeal. And that's easy to do because your Department of Insurance here does that. And so then you bring in this external group to help determine whether or not your child meets medical necessity. We almost always win those. So we tend to lose the internal appeal, and then, so I just want to make you aware of that. I think when you are denied by your insurance company, they have to provide you this adverse determination notice. It's just a letter. You definitely want to get that. The other thing we're going to talk about briefly, and probably should have started with this, but where do you find out what your coverage is for ABA, speech, residential treatment, whatever it is? You find that in these documents through your health insurer. So in insurance, we have fully funded plans, which are smaller companies. They're kind of regulated by your state. And then we have self-funded companies, Coke, Boeing, big, large companies, right? And they're regulated actually by the U.S. Department of Labor. And I gotta, this would have been a good success. The U.S. Department of Labor has taken that MAPIA, remember that patient protection thing? You got to treat people with mental health and addiction the same you do with medical surgical. And boy, they have gone after insurers like you would not believe. It's incredible. And the #1 denied service was ABA. So if you look at the reports, they've been given Congress, it's all about people with autism not getting access to services. They are a fascinating read. I'm going to put them on my website soon, so just be aware of that. So anyhow, what were we talking about? We were talking about, there was a point there I was driving at. And anyhow, Yeah, Department of Labor. Oh, okay, so, there you go, thank you. So so you know when you sign up for health insurance, they give you that grid, 80% in network, 20, whatever it is. That grid is great, but that's not what you want. You want the large document. So just remember, we need the large, like if you call your insurer and you say, I need the large document that tells me everything that's covered under my plan. It's usually about 120 pages. They'll send you a link. When you get it, just look up autism. You can look up ABA. It's called this summary plan description. Summary plan description. Sometimes it's called evidence of coverage. Summary plan description or evidence of coverage, large document of coverage, okay? That's where you're gonna find out, are there any exclusions in my health plan for ABA therapy, speech therapy for autism? Like right now, there's a plan in Ohio that says, well, we don't cap hours or visits, but we're gonna cap the age of 14. That's a problem. Remember MAPIA, Federal Mental Health Parity Law says you can't do that. So if you wanna know how much speech you can get, that's probably where you would find, well, yeah, we pay, speech therapy, we give 30 visits, but people with autism, there's no visit limit. They've been sued so many times and parents have won, right? They've fixed their policy. So I want to make sure you guys know that. Evidence of coverage or summary plan description.
And I just want to say that if you're having an experience where you're getting denied, there are multiple people out there to support with that. I know Marla and her group do a really incredible work advocating on behalf of people. Our lobbyist at ABA has been asking for denial letters just so that we can get a good idea of what denials are happening in the state and figure out how we can best advocate. So I think that the insurers, count on us not doing things in response to that and kind of just accepting those denials. But there are a lot of avenues to go through and a lot of people that are doing this work to support.
Yeah, that's a huge success. And she probably mentioned it earlier, behavior analysts are now licensed now. And that literally they just opened them up and people got licensed. So I just want to let you know, your behavior analyst you have another layer of protection in services that you receive from a behavior analyst, and they are licensed now by the state. So we're really excited about that. That's a big success. So let's open it up. Let's share, I know stories, it's hard. We have 15 minutes, but we want to hear from you, whether you're a provider, you're a family, and what you're struggling with, and so forth. So that way people online can hear too.
So I have a question. When you said down south, how far south are you talking, like providing?
So my organization is funded by DCFS. I work for UIC, but I'm in a department that's funded by DCFS, so we serve everywhere in the state. The instance I was talking about, I have some youth at Hoyleton residential, and they had been reaching out trying to find ABA providers. They did end up securing someone down there, but there was just hardly anybody in the area. I've reached out to people in like Missouri to see who's willing to come across the border and try to get individuals, because my work's in foster care, I've tried to get people to like contract with DCFS, but I think that the same issue's happening even with commercial providers and Medicaid for sure.
Absolutely, because my daughter has been recently diagnosed with intermittent explosive disorder, ADHD, and autism, and I'm in rural health and I can't find any support, and I'm south. We both are, actually. Sorry, Corey, I'm kind of putting you out there. We are, I can't find any support, and I'm between Jacksonville and Jerseyville, Edwardsville, and there's nothing around there really that has wanted to help me per se.
Yeah, and I can't promise you that I can figure that out for you, but if you want to send an email, I'll see what I can do and reach out to my contacts and see if I can find somebody to resource you in the area.
Absolutely, I'd appreciate it.
I also know that there are some behavior analysts that are providing remote services to rural areas as well. So that there might be some creative options. So yeah, I'll give you my email, and you can reach out and see what we can do to help.
Okay, thank you.
I'm glad you asked that question, because what does it mean that she can't find a provider in her area? That means her insurer is failing her. They do not have an adequate provider network. So, normally, I forget what it is, like, they'll say, well, hey, family, you can at least drive 20 miles to get treatment. Anything over 20, 25 miles is an inadequate provider network. So what I would love to do is call her insurer and say, okay, you don't have any providers down here, so we're gonna find a provider, you're gonna pay them a higher rate, and we're gonna figure out how to get her services. So that's what, so an inadequate provider network, guess what it is? It's a violation of that big old law we just talked about, MAPIA, okay? Inadequate provider network. And remember, they used to do that on purpose for people seeking mental health and addiction, to drive you out of network, which made your copays higher. Anybody else want to share something? So that was that was great. Started us off good there.
Hi. I have a foster youth that is just turned 4, and we're having some pretty significant behaviors. He's been assessed for autism multiple times. They always use the ADOS, and he flies through the ADOS with flying colors because he can make eye contact, he's social, he's charismatic, So the ADOS never captures a diagnosis for him, but his behaviors show he's clearly neurodivergent in some manner. The only diagnosis we've gotten so far is ADHD, and we're on wait lists galore. But he's on the verge of being kicked out of daycare. We're really struggling, and I'm reaching out to his case management team, but everybody's just kind of stuck. And do you have any suggestions?
Oh, do I have some suggestions? So a big part of my job is advocating, and honestly, a big part of my job is like kind of pushing the envelope with DCFS, because this is such a common problem, especially my hospital program only takes youth who have had multiple failed hospitalizations. So, I'm working with some really extreme cases. There are some avenues within DCFS, so I would say the same thing to not take up too much time, but if you want to email me, I'll support you with that. I think that when kids are at risk for losing their placement, there should be additional wrap services that you can get in home. Sometimes the caseworkers are just unaware of that. Sometimes we just need to kind of move up the chain of command. But because I'm talking to all of those people on a daily basis trying to get services, I do have some contacts that I'm happy to help if you want to send me an email.
I would love that. Thank you.
And Shannon, can you give us the 1 minute that ABA therapy isn't just for autism?
Yeah, we utilize ABA therapy to shape behavior for, it doesn't matter. I use it on my children. Not a full plan, but to shape how they're doing things. I just toilet trained my daughter. I'm using the same behavioral principles to across the board. So it is a necessary and viable option.
I also should have mentioned this before. I think it's pretty common to see people not get autism diagnosis that seem to have a lot of overlapping, and especially with the trauma. There was a article in World Psychology pretty recently that suggested having a whole neurodevelopmental spectrum because there's so much overlap between ADHD and autism. So I think that that's a discussion that is just happening in general. I think that to Shannon's point, it's not just ABA shouldn't just be used for autism, and I think that when you're getting insurance denials, there is a way that we can also fight that denial. If your youth in care, just any youth, is trying all of these other services and that's not working, then it at that point is becoming medically necessary, and so you might still be able to get ABA. It's just a little bit more work.
We did apply, and we were denied because it doesn't have an autism diagnosis. But I never got the denial letter. The provider did that submitted the prior auth, and I believe the caseworker saw it, but I never saw a letter to appeal with.
Yeah, we'll get a hold of that. Yes.
Thank you.
I've also just been chomping at the bit to like go to bat with youth care on this, so this is perfect.
Yeah.
Can I also add too, just as on the diagnostic side, so the ADOS is one tool. And so we provide ADOS trainings 4 times a year for professionals. So I feel like I could give the training at this point. But so, and our trainer is very direct when she says, and ADOS is one tool. And so just because someone might not score in that autism range on that instrument doesn't mean that they don't get the diagnosis. I've done that. Like I've conducted diagnostic evaluations where the ADOS, they did great, but all the other data that I collected would say otherwise. So I think continuing to advocate on that piece, it is good, and just having that knowledge.
Yeah, and guess what? One of those other MAPIA protections we have is something what they used to do to people called fail first. Hey, you think the child needs ABA, but we're going to first do counseling. And if it fails at counseling, then we'll do ABA. They can't do that anymore, right? You know, if you know that child went to Shannon and Shannon diagnosed him for whatever disorder it was, but she prescribed ABA, recommended ABA, then you would go back to the insurer and say, I hear you're providing, you say there's coverage for counseling, but we were prescribed ABA. That's like, I'm here for my physical physical therapy for my knee, but you're saying you're going to give me a facial. I mean, that's not what I was prescribed. I'd like the facial, but so that's called fail first, where they say, well, we'll authorize a lower level treatment. That's not what you want. That's not what we were prescribed. And oh, by the way, what probably could happen now is, well, you denied it. Can you please share what provider or service I do have coverage for to address these behavioral problems? Because then they're not going to answer back. They could say day treatment, partial hospitalization, whatever, but, you know, so, yeah. What else? Anybody else got a comment, thought, challenge? Yeah?
MAPIA that you were talking. So you said there's no longer caps through insurance, correct?
Yes.
So what does it look like when they get when they say, oh, we do cover ABA therapy, this is the coverage. Like, so how does that?
Oh, the coverage says there's a cap.
Well, so they're not supposed to have a cap anymore, right? Is what you're saying?
Yeah.
So then so what does that look like? Like they just get all the hours, or they say based on medical necessity, this person gets less hours, more hours, but like how does that work now? I guess is my question.
Yeah, so insurer will use the medical necessity process that they have to bring down the hours, right? And they may have a legitimate reason, right? So just so everybody knows, ABA is not 40 hours a week anymore. It's an individualized need. So these guys will say, well, you know, Johnny needs 20, Cindy needs 6, you know, yeah, Sam does need 40. So just so you know, it's, you know, we have comprehensive ABA, that's the very large, big delivery of ABA for lots of developmental domains, and then we have focus. So your question is, so the insurer says, well, we don't cap hours, but we determined through the medical necessity process, the kid only needs 30 hours. So the provider would have to come back and say, well, we disagree. Our clinical judgment is the child needs 35 hours. And they're going to say, well, we'll approve 30 and hours. Which really, what are they saying? We're going to deny 5 hours and give you 30. And then sometimes we get into this thing where they'll say, the provider will, give me 32. Okay, we'll give you 31. It's like this bartering every now and again. So just so you know that, so we always go back, the behavior analyst, psychologist, whoever's delivering this, it's their clinical judgment we're trying to get. If my doctor says, Marla, you need 20 visits for your knee, but my insurer only pays for 15, I've been partially denied. And what happens when we're partially denied? We asked for 35 hours, we got 30. We want that adverse determination notice so we can file an appeal. Sometimes, you know what I love is when they say, well, this kid should be in school. So if the kid goes to school for, you know, 7 hours a day, and then they come home and they need to play for 3 hours a day, and then they have dinner and bath time. So there's really only room for 2 hours of ABA. If my child had cancer and I had to go daily for treatments, are you going to tell me I can't go because of school, bath time? I mean, literally, we hear this stuff. So we need to, when ABA is going to be utilized as a medical treatment, it needs to be delivered based on the clinical judgment. And then sometimes we do, get that tug of war type stuff with the insurer.
Is that the same for Medicaid too?
That's the same for Medicaid. Yeah, I was just in a hearing on this exact case. Well, Marla, the kid should be in school. Well, the kid has autism, which is a mental health disorder, and he needs treatment. And oh, by the way, if he never gets the treatment, he's never going to get back into school. So you tell me what we're doing here. You tell me what we're doing here.
Yeah, and I would just, I wanted to add that in our conversations with HFS, that we've brought some of these things up, and then they're, following up with notices too. So if you guys are running into things like that, definitely let us know so that we can move that up the chain of command.
Yeah.
Also, by the way of clarification, so if a child was diagnosed at 7, but now is 11, that previous diagnosis is worthless?
It's not worthless, but the insurer will say, well, we don't know what the kid's been doing the last 4 years, and maybe they don't have much autism or less, the symptoms are impacting them less. So
More.
we need to know what's happened in the last 4 years before we're going to authorize treatment. I mean, that's really kind of what they're saying. Okay. So, I mean, so we would say, thank you. She's telling me. So basically, the insurer is saying, okay, the kid was diagnosed at 7, they're now 11. We don't know how much developmental gains they've had because maybe they don't really need ABA. Well, we would say, hey, somebody has just done, right, the behavior analyst, right, before you get ABA, they have to do an assessment. The assessment determines those core deficits that need treatments, they develop treatment goals, and so forth. So obviously something's going on because they did the assessment and they want to serve the kid, right? There's goals there that the kid needs to work on. What we would say is, listen, we'll go back to the licensed, social worker, psychologist, physician, and we'll just have a conversation with them, tell them what's been going on, and we'll get the prescription. And then we'll send it into the insurer. And then if you want us to get in line for that comprehensive big diagnostic evaluation, we will. But do not deny treatment. If I was diagnosed with juvenile diabetes, 3 or 4 years later, I probably still have it. When I go into the doctor's going to be like, yeah, we'll continue your prescription, let's get a blood draw. We don't, kids with autism tend not to lose, some do, their diagnostic. It's a lifelong condition is considered, so why are we, because it's going to take that family almost 2 years to get back into treatment. Does that make sense?
Yeah, so the way to initiate initially, so the way to initiate, it's in the same word, is what?
You give them a psychological evaluation from 7. You'll say, hey, listen,
Give it to whom?
well, to the insurer. Okay, so the provider of services. The provider of services will give that psychological evaluation when they send that prior authorization request into your insurer. And then the insurer may come back and say, nope, we want a new one. And you'll say, hey, listen, we'll schedule a meeting with Johnny's psychiatrist and we'll get a new prescription and he'll say he needs services and we'll send that to you. Now, if they deny you, that's when we need to file the appeal. Say, hey, listen, what are you doing? It's a lifelong condition. He's 11. Clear core deficits that need treatment based on the behavior analyst assessment document. I have a psychiatrist says he has autism. They can diagnose. So what's the holdup? We need to start treatment, and we'll go get in line for that big evaluation. Are we at time? Yeah, we are at time. Thank you, guys. This was so fun, and come on up and talk to us. We'd love to talk to you, and we'll definitely I'll give you my email because it's easy. And then I can share. My email is the word help, HELP, at ILASD.com. Help at ILASD.com.
Marla and I talk every week, so you don't have to worry about that not getting to me.
Could you give us your name again, though, because for the foster care, I think we're...
Yeah, my name's Jamin, Jamine. There's only one of me in the States, so you don't need my last name. No. my last name's Detmering. It's just a mouthful. Dettmering.
Now you want Outlook then? Okay. We can find you.
Oh, for the, like, DCFS?
Yeah.
Mm-hmm.
Yeah,